So my presentation today would be on manual CARES with or without cross-linking for keratoconus. CARES stands for Corneal Allogenic Intrastromal Ring Segments. It was developed in 2016 by Dr. Susan Jacob. Corneal stroma from donor cornea used to form strip resembling intrastromal corneal ring segments. This was mostly done by creating intrastromal tunnels by femtosecond laser. Parker et al. In 2021 published an article in JCRS where they used manual corneal separators and microkeratome system to create intrastromal channels. They concluded that manual CARES implantation is technically possible and may be a viable option where femtosecond is unavailable. Our technique is somewhat similar to what was described by Parker. However, we do not employ a microkeratome suction device to stabilize the globe. We rely on a modified corneal dissector, which we name as OR Corneal CARES dissector. It has sharper blades and a bulkier diameter to create greater torque. So on the left hand side we have the trifine used by Parker, and the right hand side is the one designed by us. So this is based on this equation of creating a greater torque by just increasing the diameter of this trifine, and we have to amount less force in creating so. So ours was a prospective case study, and the aim was to study the topographic and visual acuity changes after manual CARES combined with or without CXL. So keratoconus with minimum pachymetry of 370 microns were included. 1 mm wide CARES segments were prepared using Jacob CARES trifine. Peribulbar block was given. Arc length of channels was masked using a Mendes gauge in 6 mm optical zone. Partial depth incision made using partial depth blades, that is 300 microns, and 1 mm intrastromal channel created using OR dissector, and the incision was closed with 10-0 nylon. So this is the part where we create these segments, CARES segments. We remove the epithelium, endothelium on both sides, and here we are using a simple trifine. This is a button which has been previously used for a 7.5 mm optical keratoplasty, and here we have made a uniform 1 mm thick strips. We stain it with trypan blue and divide it in 2 segments. And they can be left over a Mirocell sponge to dry, or else they can be used in a non-dehydrated state as well. Here we are marking a central 6 mm zone using a trifine, and using a Mendes gauge we create the arc length. This is a partial depth incision 300 microns, creating a channel pocket, and this is our channel creation using the modified dissector. We have to be parallel to the iris plane all the time, and these are the pre-cut strips. And you can see these can be incorporated into these channels using reverse Segmentscairs hook. We trim it to a proper length and close the wound with 10-0 nylon. So post-op regimen is like steroid antibiotic combination 4 times a day for a week, and then tapered over a month. Tear substitutes SOS, and we usually remove sutures in 2 weeks time. So these are the results. You can see the cylinder has gone down from -10 diopters to -4.85. Similarly, this is showing a intrastromal CARES segment. Again, we can see good refractive results here, cylinder coming down from -5.5 to 2.25. So 24 eyes with keratoconus were treated. 16 cases were standalone cases. 8 were combined with accelerated CXL. Mean follow-up was around 10 plus minus 3.5 months, and significant improvement was noted in uncorrected visual acuity and corrected visual acuities for distance. SIM-K keratometry, astigmatism, and steep keratometry all showed a decrease in all cases. All cases remained stable in post-op period, and no major complications occurred. So the clinical implications are, this study proves that efficacy of CARES in treating keratoconus as shown in previous studies. Manual CARES can be safely performed by every corneal surgeon without investing in expensive and high-end equipment. Learning curve is not so steep. With further modification and refinement in instrumentation and technique, a standard protocol can be formulated to make the procedure more consistent and predictable. Thank you.
Did you combine this with the cross-linking?
Yes, not all cases. There were many cases, like 8 cases were such where previous cross-linking was done. So in those cases, we just did standalone cares. Many cases were combined. We first do a cares, then remove the epithelium, and then proceed with the cross-linking.
What is the minimum thickness of cornea you are taking?
What we are taking is 370 microns. We are not going below 370.
Excluding epithelium?
Including epithelium.
Including.
What was your cutoff for a topography? Like how steep the cornea, maximum steepness of cornea that you had taken for a cares?
So usually we didn't take cutoff for keratometry. Our cutoff was very thin corneas. Suppose if the thickness was less than 370 microns, then we didn't go for it.
And in case if the thickness was 410 and if the K1, K2 were somewhere in the range of 58, 64.
Yeah.
So you had like
yes,
still.
We have done those cases.
And any cases of you had a epithelial ingrowth or something?
No, not yet. The mean follow-up period was around 6 to 12 months. Till now, we have not seen any cases of epithelial ingrowth.
And how long you continue with topical steroids?
4 weeks.
So after 4 weeks, you're discontinuing everything.
Yeah.
Good. Okay. Thank you.
Thank you.
Thank you.
One question is there for you. One question is there. Yes. You checked about the astigmatism? Checked about the astigmatism?
Yeah.
And what is the result of?
We checked both using a topography as well as.
Now, what is the result you found? That I wanted to know. Regarding astigmatism.
Yes, the same keratometry showed a mean decrease in 4.6. Astigmatism showed a decrease in 5.1 diopters. Mean.
Okay.
Yeah.